Hello everyone, my name is Jem Nainen. I'm a rheumatologist from Adelaide, and today I'm going to be discussing giant cell arteritis and polymyalgia rheumatica. Some historical background. Giant cell arteritis was described as early as 1890 by Jonathan Hutchinson. Giant cell arteritis is the most common primary vasculitis of the elderly. It primarily affects people over the age of 50 and peaks in incidence by the age of 80. Women tend to be more commonly affected by giant cell arteritis than men, and the incidence is highest in the Scandinavian population. Here is a map of the world with incidence of giant cell arteritis in the various countries. Giant cell arteritis affects the medium and large arteries of the body, and in particular the external branch of the carotid artery, the ophthalmic, vertebral, distal subclavian, and the axillary arteries. The thoracic aorta is also affected. The pathogenesis of giant cell arteritis begins in the adventitia of the artery with danger pattern recognition on the vessel-specific toll-like receptors of the vascular dendritic cells, which reside in the tunica adventitia of the artery. Once these are activated, they produce T-cell attracting chemokines CCL19 and CCL21, which draws T-cells into the media. Peripheral blood monocytes then differentiate into tissue macrophages and eventually form giant cells. They produce interleukin-6 and interleukin-1 beta. Interleukin-6 induces T-cells to differentiate into Th17, which is steroid responsive. Tissue macrophages also produce interferon gamma and platelet-derived growth factor, as well as vascular endothelial growth factor, which are associated with ischemic complications. Notch receptors, which are bound by Notch ligands, tend to amplify the inflammatory response by increasing myofibroblasts that proliferate in the intima, and this leads to narrowing of the vessel lumen. The symptoms of giant cell arteritis are related to systemic inflammation and also because of ischemia from the luminal narrowing of the intima and media of the media of the artery. The study of 693 patients described 4 distinct clinical patterns of giant cell arteritis. They range from an isolated cranial giant cell arteritis, which is seen in almost 80% of the patients. They present with headache, jaw claudication, and scalp tenderness. There can be symptomatic large vessel vasculitis in about 9 or 10% of patients with claudication and pulseless limb, and these patients may or may not have cranial signs. Another 9% of patients may present as having isolated fever or just the inflammatory response, and another 2% of patients can have polymyalgia rheumatica with presence of vasculitis on imaging. Large artery disease is seen in 29 to 83% of patients with newly diagnosed giant cell arteritis. Giant cell arteritis patients with large vessel involvement tended to be younger. They were less likely to present with headaches, and they were less likely to have a positive temporal artery biopsy. They were at lower risk of visual loss, but they tended to require higher steroid doses, and they were at higher risk of relapse. The eye symptoms and signs of giant cell arteritis can be related to vision loss, which may be partial or complete. They can also present with transient visual blurring, sometimes sudden loss of vision. They can occasionally have eye pain, diplopia, ptosis, nystagmus, and internuclear ophthalmoplegia are also seen. As you can see on the fundus examination of the eye, you can see cotton wool areas and also the cherry red spot. The causes of vision loss in giant cell arteritis is mainly from anterior ischemic optic neuropathy and occlusion of the posterior ciliary arteries here, which causes almost 80% of the visual impairment in giant cell arteritis, but only 5% of patients with anterior ischemic optic neuropathy is caused by giant cell arteritis, Other causes include non-arteritic causes, including diabetes and hypertension. Posterior ischemic optic neuropathy, central retinal artery occlusion, and branch retinal artery occlusion are less common causes. The American College of Rheumatology developed a classification criteria for giant cell arteritis. It's important to note that these are classification criteria and not diagnostic criteria. The problem with this is it fails to diagnose patients with predominant large vessel involvement and also fails to distinguish between other causes of headache associated with inflammation. It's always important to look at the possible differential diagnosis in patients who present with these symptoms, and where headache is the main symptom, be sure to consider other causes including cluster headache, migraines, tension headache, sinusitis or trigeminal neuralgia, ophthalmic herpes zoster, or sometimes skull metastasis can also present with headache and raised inflammatory markers. Other situations where high ESR and CRP occur and maybe a diagnostic challenge can be in patients with polymyalgia rheumatica. Some of these small vessel vasculitis small and medium vessel vasculitis can also affect can also produce headaches and elevated ESR and CRP. Other conditions including malignancy and temporomandibular joint disorder needs to be kept in mind. The investigation we usually do are the blood counts, biochemistry, ESR and CRP. About 4% of patients will have normal ESR. The alkaline phosphatase and platelet count is often elevated. Chest X-ray should be done to exclude aortic aneurysm and other abnormalities. A CT scan of the head is recommended to rule out headache, to rule out other causes for headache. Acute phase reactants can be helpful in the diagnosis of giant cell arteritis, and we look at a cutoff of over 50 millimeters per hour for ESR, more than 20 for CRP, and 300 for platelet count. The specificity is about 57% for ESR and 68% for CRP in the patient with headache and other clinical symptoms suggestive of giant cell arteritis. A combination of CRP and platelet count may be the best diagnostic combination with regards to acute phase reactants in giant cell arteritis. However, despite all this, no highly specific biomarkers have been validated for giant cell arteritis or polymyalgia rheumatica, and there is no evidence that measuring interleukin-6 level is superior to CRP. Temporal artery biopsy is the gold standard, and the sensitivity of the temporal artery biopsy is about 70 to 90% in patients with cranial giant cell arteritis. This can be as low as 52%, however, in patients with predominantly large vessel giant cell arteritis. The temporal artery biopsy can be negative, particularly because of skip lesions or sampling errors, or in patients who've got predominantly extracranial large vessel giant cell arteritis. Because of this, the role of imaging has become more important, and it's particularly useful in patients with large vessel involvement. However, imaging sensitivity tends to drop off within 2 to 3 days of treatment with steroid. Imaging may be part of the diagnostic or classification criteria in the future. We use ultrasound, MRI, PET scans, and CT angiograms for the diagnosis. High resolution 3 Tesla MRI of the scalp artery can be quite useful in diagnosing giant cell arteritis, particularly with the gadolinium enhancement. There is increased changes, as you can see, typical of inflammation in the high resolution scans. This prospective study was quite helpful in determining the usefulness of MRI for the diagnosis of giant cell arteritis, and it was found that it had a sensitivity of 93.6% and a specificity of 77.9%. The most useful part of MRI is that it has a strong negative predictive value of 98.2% for biopsy positive giant cell arteritis. Ultrasound is helpful, particularly in rapid access clinics for the diagnosis of giant cell arteritis, as it is portable and can be performed at site. The inflammation of the temporal artery wall can be visualized with a high frequency ultrasound probe, and it appears as a dark concentric ring or hypoechoic halo. We can also image the superficial temporal artery and the axillary and subclavian artery, which gives an improved sensitivity to the test. This large study of temporal artery ultrasound compared to biopsy in Europe looked at 381 patients, and these patients underwent both ultrasound and biopsy within 10 days of starting treatment, and the sensitivity of biopsy in these patients was low, up to only 39%. Ultrasound was about 54%. The specificity of ultrasound, particularly with the halo sign, was as high as 81%. The CT angiogram of can be helpful, particularly in looking at the larger vessels, as can be seen in this one. The PET scan can be particularly useful in patients with giant cell arteritis with signs of increased uptake in the in the large blood vessels. Giant cell arteritis is considered present when the uptake is more intense in the aortic wall compared to liver or blood pool, and it performs quite well as a test in diagnosing large vessel inflammation in GCA. The sensitivity was 89.5% and specificity up to 97.7%, particularly in patients who got a diagnosis of GCA. It is important to start steroids as soon as giant cell arteritis is suspected, because the risk of vision loss in the other eye is high, and however, once steroids are started, the risk of vision loss decreases significantly, and in this study the 5-year probability of vision loss after starting steroid was down to less than 1%. Giant cell arteritis has a number of complications related to both the ischemia as well as to treatment of giant cell arteritis, and these include infections, which is particularly high in the first year of diagnosis. One has to bear in mind there is the complications associated with steroid therapy, including osteoporosis, cataract formation, and the impact on diabetes control. Interestingly, the overall cancer risk after the diagnosis of GCA was not particularly increased. There are long-term risks associated with giant cell arteritis, and one needs to monitor for aortic aneurysm. This seems to be a late complication and seems to occur 5 years after giant cell arteritis diagnosis. The risk seems to be higher in patients who are male and had a positive smoking history and hypertension. There is, however, no current consensus on how to monitor these patients for aneurysm, and generally we recommend at least annual chest x-rays. The treatment of giant cell arteritis began with glucocorticoids and as early as 1957, and the treatment advances have not been significant until recently, with the addition of more specific therapies. Patients receiving initial oral prednisolone dose of more than 40 milligrams were more likely to reach a dose of less than 5 milligrams and discontinue steroids sooner than patients who started off with a lower dose. The incidence of steroid-related adverse effects is very high, around 86% at 10 years. And there is higher risk of infection, as mentioned earlier, in the first year. The interleukin-17 axis in the pathogenesis of giant cell arteritis, as we know, is steroids responsive, whereas the interferon gamma axis is relatively resistant to steroid therapy. Aspirin can have a positive role in the management of giant cell arteritis, as there is some benefit in suppressing interferon gamma. There's a positive role, as you know, in cerebrovascular disease, and there is some reduction in rate of vision loss and ischemic complications in patients on aspirin. What about methotrexate? Methotrexate has had 3 randomized controlled trials, and an individual patient data meta-analysis showed that there was a reduction in the risk of first relapse by 35% and the rate of risk of second relapse by 51%. Methotrexate, when combined with prednisolone and placebo, also reduced the median cumulative dose of prednisolone, which was down by about 1,302 milligrams. Cyclophosphamide has been used to treat giant cell arteritis as well, but the use is limited by its toxicity. Azathioprine has also been studied, and it shows a reduced lower mean prednisolone dose at 52 weeks. A few small case series of flunomide has been shown to be beneficial in the treatment of giant cell arteritis and helps reduce the amount of steroids that are required. Combining conventional disease-modifying agents have not been studied as such, although methotrexate and azathioprine have been sometimes combined, although this combination has not been studied. Anti-TNF therapy is not recommended for the use in giant cell arteritis. This is an interesting picture of from the 16th century with Canon van der Perl, who has been shown to have this enlarged temporal arteries, and he apparently had poor vision towards the end of his life, and one wonders if he had giant cell arteritis. Tocilizumab has been studied in a double-blind randomized controlled trial in giant cell arteritis, and this was a multi-center study for 52 weeks with 4 arms, with tocilizumab given along with prednisolone weekly, fortnightly in another arm, and then compared with placebo with prednisolone taper for 26 weeks or to 52 weeks, and in the 4th arm. The results revealed sustained remission at week 50. The primary outcome was sustained remission at week 52, and this was seen in 56% of patients treated with tocilizumab weekly, in 53% of patients who were treated fortnightly with tocilizumab, and in the placebo group only 14% were in sustained remission, particularly those that were tapered off to 26 weeks. By 26 weeks, the longer taper had 18% in remission. The cumulative prednisolone dose was also significantly lower in the tocilizumab group, down to 1,862 milligrams as opposed to 3,818 milligrams in the 52-week taper group. As you can see, the survival curves here, which show the tocilizumab group, which had the least flares in the first 52 weeks. There were a series of adverse effects in 15% of patients with the tocilizumab weekly group, and 22% in the placebo group, and 25% in those who were taking prednisolone for 52-week taper. One of the patients who was assigned to the tocilizumab group developed anterior ischemic optic neuropathy and had to be rescued with glucocorticoids. There was one patient who also had a thrombotic stroke in the trial. However, this leads to some unanswered questions. We do not know what the relapse rate of after discontinuing tocilizumab after a year is. We don't know what the long-term rates of ischemic complications are. This study tried to answer that, and 17 of the patients, of the 20 patients that were randomized to the tocilizumab treatment arm, had lasting remission at 52 weeks. After discontinuing treatment, 8 patients relapsed within about 6 months, and another 2 patients after 13 and 14 months. The patients who relapsed were younger, and they had more signs of mural enhancement on the MR angiogram. Ustekinumab, a single open-label study revealed some benefit of ustekinumab in the treatment of giant cell arteritis. I have a few slides on the other studies that have been done for giant cell arteritis using other drugs. In summary, giant cell arteritis is still a clinical diagnosis. Temporal artery biopsy is still very, very relevant. Glucocorticoids are a blunt but very effective tool, and is still the mainstay of treatment. We'll switch gears to polymyalgia rheumatica. Polymyalgia rheumatica overlaps with giant cell arteritis, and many patients with giant cell arteritis can have symptoms of polymyalgia rheumatica, and it's more common the other way around. Many patients with polymyalgia and some patients with polymyalgia rheumatica can develop giant cell arteritis. Polymyalgia rheumatica, as you know, is a clinical diagnosis, and in 2012 there was a classification criteria for clinical studies into polymyalgia rheumatica, and they had 3 mandatory criteria, namely age over 50, and aching in both shoulders, abnormal CRP and ESR. Additional criteria included use of ultrasound, which included the presence of morning stiffness lasting more than 45 minutes, reduced hip range of movement, negative rheumatoid factor, and CCP was important because rheumatoid arthritis can be a differential diagnosis for these patients, particularly seronegative rheumatoid arthritis. The absence of peripheral synovitis is important, and if you can find ultrasound signs of subdeltoid bursitis or bicipital tenosynovitis, this can be helpful. If it is bilateral subdeltoid bursitis, they get 2 points. These patients present with aching and stiffness around the neck and shoulders and the lumbar region. There is prolonged morning stiffness. Muscle strength is normal, but the testing is limited by pain. Polymyalgia rheumatica can be associated with depression, fatigue, and weight loss. Interleukin-6 has a central role in mediating inflammation, and there are decreased T regulatory cells and Th1, but there is elevated Th17 cells found. It is important to look at polymyalgia rheumatica as it is, particularly with differential diagnosis, as seronegative rheumatoid arthritis, regional soft tissue rheumatism like subacromial bursitis can present with these findings. Myeloma and other malignancies needed to be considered. Patients with myositis can be also a differential diagnosis. Drug-induced myopathy and myalgias, fibromyalgia, Parkinson's are also differential diagnosis for patients with polymyalgia. The investigations we usually do include ESR and CRP. We would like to exclude seropositive rheumatoid arthritis by doing rheumatoid factor and CCP. Protein electrophoresis and muscle enzymes are important to do as well. PET scans can be useful in those patients where the diagnosis is unclear, particularly helpful in ruling out other causes. And this can show increased uptake in the interspinous bursa, as well as in the subacromial bursa and around the ischial tuberosities. Polymyalgia activity score can be derived by this formula, which uses morning stiffness, the ability to elevate the arms above the shoulder, physician global assessment, and patient pain visual analog score, and the CRP. A score less than 7 seems to define low disease activity, and a score of more than 10 is usually what we use to define a flare and can help us make a guide in adjusting the steroid dose. Most patients with isolated polymyalgia rheumatica tend to respond to low to moderate doses of prednisolone, around 15 milligrams, and they respond within 48 to 72 hours. Typically, prednisolone is 15 milligrams is continued for about 4 weeks and then reduced by 2.5 milligrams every 2 weeks until the dose is 10 milligrams per day. This is subsequently reduced by 1 milligram each month. Relapses occur during steroid reduction and may require a return to the previous effective dose. Methotrexate has been trialed in polymyalgia rheumatica, and it allows a lower dose of prednisolone to be used, particularly in patients who relapse. Etanercept has been, anti-TNF agents including etanercept has been tried with very limited benefit. It does ameliorate disease activity, but the effect is modest and indicates only a minor role for anti-TNF with PMR. It's important to monitor bone health, vaccinate patients to reduce risks of infections, particularly with the long-term use of steroids. Thank you.